So thanks, Dan. That wasn't really fair because that was an amazing talk, and now I have to follow that. But thanks for setting me up. so, so I'm just going to talk a little bit about my experience with stereotaxis. So, which is different, potentially from other folks. So, I did all my training at the University of Pennsylvania. Sort of came through fellowship and then started as an attending. And sort of the advice that was given to me when I started as attending is don't do anything different than what you learned. So don't adopt new technology. Don't do what you feel comfortable with. So I didn't have much experience as a fellow, to be honest. We had our hands on the catheter pretty much 24/7, day, night, weekend, didn't matter. I had our experience with that. So I really didn't feel like this was a technology that I needed. I thought that I can do all these procedures, and one of the things that I had concern of adopting this sort of as a new technology a couple years out from becoming attending was what's the learning curve? I don't really want to be in the hospital when it's dark. I would like to see my wife and my son. And I think they like to see me once in a while. And so is this going to increase my duration of procedures? And so, we collected that data and I looked at it. And so this is my, first 20 procedures, and you can see that you would expect normally with any type of procedure that you start doing in the beginning that there is a learning curve, and then eventually it sort of plateaus. For me, it was from pretty much day one, my procedural times were the same or if not better. And so, which I was surprised with. I said, there's no way that I can do this faster if I'm using technology. I have to take the time to come in and out of the room and bring magnets in, and that actually was not the case at all. And so, the other thing that I sort of thought wasn't necessarily going to be helpful would be contacts, right? So I was used to contact force and sort of having my hands on the catheter and being able to feel that, and I can get to any part of the heart. I don't need a robotic system to be able to get to the LV summit or the cusp or the AIV. Well, that level of bravado starts to go away over time as you realize that you want to do what's best for your patients. And so if you see some of these images, you can see some really cool stuff. If you do this with a manual catheter, good for you. It's impressive, but you can see some of these images of getting to interesting locations easily and not worrying about tying the catheter in a knot. So stability is something that Dan sort of had talked about as well, and so you can see here that the motion of the heart with a manual versus robotic catheter. You can see the difference here of the sort of catheter moving and touching at times versus stability all of the time. And in fact, once in a while when I'm doing cases, my cardio rep will say, I think you might have moved, and I'm like, no, that's not possible because my hand is not on the mouse. So that catheter did not move. The patient's taking a breath, I promise you. And so it really does increase stability, which I was surprised at as well. And so you can see sort of a video here showing sort of the same thing. The idea almost, you can see it's sliding back and forth with a manual catheter versus really being in one place all the time, which is really important in terms of PVC ablations. These procedures are either the most satisfying or the most miserable things that you do in the day in the EP lab. And honestly, when they're satisfying, you cure people. You fix cardiomyopathies. You have generally young, healthy people that they give you a hug at the end of the day if you fix them, or they don't if you don't fix them. And so these are one of these procedures that you really want to have a good success rate, as sort of Dan alluded to. So catheter stability is something that helps significantly with these procedures. So I'm going to show a couple examples of cases that I did. So so this is the first sort of hesitation that I had with using stereotaxis is that I did everything retrograde in terms of access to the left ventricle. So if I was going to do a cusp case, I just assumed that you would have to do it that way, and that going transeptal was something that I never really considered as a possibility for cusp PVC. But it turns out, one, it's nice not to have to get arterial access in patients. To be honest, the majority of complications that I had as a young attending were groin complications, and arterial complications are a dissection. And there's some good data sort of looking at transeptal versus retrograde approach to the left ventricle. But you can see that this is approached from on the other side, and this was a case, that we did in about 40 minutes. The patient was assessing the end bigeminy, and we were able to get suppression very quickly, as you can see, sort of on the other side. And I actually have found, at least in my experience, that I've been able to get every PVC coming from the cusp location from a transeptal approach underneath. And it turns out, and this was sort of, they forced me to do this. I was like, no, absolutely not. I'm going retrograde for this case. And then after I put a big sheath sort of going around, I'm like, wait, all right, let me go transeptal. And we actually had very good success. I've been able to, knock on glass or wood, all of these cases from this approach on this side of the cusp. And I'm not sure if I have a slide showing you, but you can also retroflex the catheter back on itself to access the aortic cusp on the other side if you need to. Turns out for me, I haven't needed to. I've been able to get each one of these from right underneath going transeptal. So this case was a 23-year-old teacher for special needs children who essentially could not function because every PVC she had would debilitate her. And so, we brought her to the lab, and you can see here actually that the first case that I did with her, this is not that dissimilar to the case that Dan had showed, where we mapped the right side, we mapped the left side. I did ablation underneath the cusp, the area that was closest, and we got suppression 1 minute, 2 minutes into the burn, but then it came back, and then it came back, and then it came back. And so going out the AIV, or out the vein to be able to look for PVCs is incredibly easy with this catheter. And the ability to sort of manipulate it and get it out to an area that you need to without having to worry that I was going to perforate this young person's heart is incredible. And so, we're able to get the catheter out the AIV with ease, ablate there, and then immediate termination. So, like I said earlier, a huggable moment. So, let's see if this plays. Unfortunately, it didn't. So ventricular tachycardia ablation is something that you do a lot of if you train at the University of Pennsylvania, and these were cases that took hours and hours and hours, which is great if you have a fellow, but if you don't, which I don't, my back starts to ache after hour 3, 4, 5 into a procedure, and so being able to get sort of high fidelity maps to ablate areas of scar and workflow is something that we adopted with a combination of use of stereotaxis and multi-polar catheters. And so this is a map that we did, gathering over 700 points in under 10 minutes. So in my workflow, to get into the left ventricle, we go transeptal. I use the ablation catheter to sort of quickly define where the areas of scar are, if I'm not sure based on an MRI or some other imaging modality. And then I sort of come back in, use a multiple catheter. In this case, it was a Pentaray, define the scar in more detail, and then in this case, able to do substrate modifications. And so, I was able to do, and again, I apologize that these videos are playing, but ablation for an hour, 1 hour of substrate modification while sitting there and having a cup of coffee. So, the ability to do what are very long and complex cases, and not have to stand and wear lead and sort of go in and out of the lab, having the technician, update the Pruka or pace here or entrain here, made my life so much easier. And honestly, had very good success rates in terms of using this for ischemic, non-ischemic cases. So papillary muscle PVCs are sometimes my nightmare. You see sort of an EKG of this sort of 2-3 discordant PVC, and you're like, oh, this is going to be a long day. And contact on this area is particularly difficult. And I remember doing these cases as a fellow, and you're trying to balance on an intercavitary structure in a moving heart. And yes, we all believe that we have the best hands in the world, but quite frankly, if you can have something do it for you, your life is a lot easier. Now, we've published a pen, the use of cryoablation, which I think of sort of as, the scene from A Christmas Story where the kid sticks his tongue, stuck. So this is sort of a corollary to that. And so the catheter can very easily be placed on intercavitary structures and not have to worry, one, about the catheter moving and the ability to deliver energy there, And so when I would do these cases manually, and we would try to look at the signals and say, what does the unipolar look like? And by the time we got it and said, all right, this is exactly what I want to do, can we come on ablation? The catheter had already moved. And so, I don't have to worry about the catheter moving anymore, and I don't have to yell. I can sort of softly talk to the people that are all in the same room with me to do these cases. And so this is just sort of another example, and you'll see some of these cases you're just burning and burning and burning. And unfortunately, with a lot of this, once you start to sort of, if you do the learn by burning approach, you get edema in the area where you actually want to get to the tissue and ablate, and then you can't suppress it, or it comes back, it sort of comes, goes, and then you really don't have any opportunity to do that. So the ability to deliver a lesion immediately to suppress an area, and in this case a posterior medial papillary PVC. And again, these cases that I'm showing you, for me in the past, with a good amount of experience doing PVCs, would take hours and hours. And I've been able to do this much quicker, much easier, make my life better, and make my patients' life better. And so this is another example of that workflow that I described to sort of very quickly get to an area of the heart. So you generally sort of, as I mentioned, start with, you can see here, this is a cardo sound shell, and using the ablation catheter to just go to different points in the heart, figure out where that scar is, and then take 15 to 20 points, and then switch out for a multiple mapping catheter. Now you don't have to do this. You can do this with a single catheter, but in this case, I'm sort of using a combination of both. Concentrate on the area of scar, find out where exactly those regions are for, in this case, scar homogenization and substrate modification. And so 400 points, and then be able to basically go in and carpet bomb this entire area of scar easily with sort of minimal effort on my part. And so I really love being able to use this for a substrate modification for either ischemic or non-ischemic VTs. So here you can see, again, this patient was non-inducible after lots and lots of ablation, and the entire case took us less than an hour. So to do an ischemic VT in less than an hour is pretty difficult, to be honest. And so I've been impressed with the ability to enhance my workflow and speed of these procedures, but also sort of make my life easier and sort of safer for the patient as well. So this was sort of an entire time, less than 1 hour, non-inducible, certainly happened. So, and this is sort of another example of an aneurysmal ischemic VT. So the concern is certainly in aneurysmal tissue is that it can be thinned. If you take a catheter and you push hard, you can perforate in that area. I have no concerns whatsoever about perforating. The catheter, with stereotaxis, it's like a wet noodle. You can pretty much go wherever you want, and you're never going to worry. The catheter will buckle on itself. It will not go through, the tissue, whether you're in the vein or, in this case, in the left ventricle. Same workflow, mapping points. You sort of determine the area of scar, then switch out for a multipolar catheter, define that even more, then come back to that area and deliver that energy. And so you can see here, this is, again, another example of sort of extensive ablation. In these cases, I'm hitting 999 on the generator, and then coming on again, coming on again, coming on again. And not worrying about, sort of the amount of time that I'm spending doing it, because I'm not getting operator fatigue. And, as much as we like to think that we can do these cases for very long periods of time, we get tired. And this allows you to sort of deliver energy for very long periods of time. And then just another example of that. So you can see sort of going transeptal and then the catheter sort of coming back on itself to be able to deliver good contact and good burns for very long periods of time. Again, another sort of successful VT case. This is a case that we did. So initially when we were first doing cases, the folks from stereotaxis would approach me and say, well, why don't you start by doing something like an outflow tract PVC? And I said, well, why do I need you to do an outflow tract PVC? I can do these cases, in 30, 45 minutes. But it turns out that sometimes it's quite difficult to get the catheter out to the outflow tract, and and these are young, healthy, small hearts that if you're on the RV free wall and you're pushing and you're using a steerable sheath like an Agilis, you can perforate. And I've certainly had those cases in the past where we've had to drain effusions for young, healthy people. It's one of those things that raises your pulse when you're doing these cases. And the ability to get to the PA and deliver lesions, and also to come back on itself so that you can deliver lesions on the other side of the pulmonary annulus is something that stereotaxis can do really well. That in the past, I always had concerns about manipulating a catheter all the way out there without causing, again, perforation. So here's an example of that case that I mentioned, was unable to suppress this outflow tract PVC from sort of the standard approach that you get when you're underneath the cusps. And what I sort of learned is that sort of approach to the aortic cusp you can also do on the RV side. And in the beginning, I didn't necessarily have that sort of concept. So here you can see the catheter sort of come back around into the main PA, flip back around and deliver a lesion easily. And this is really easy to do, and suppress an outflow tract PVC. This is another example of an AIV, or great cardiac vein PVC, in a patient that we mapped the entire left ventricle, the entire right ventricle, nothing early, thinking that I was going to have to go epicardial on this patient. And then you can see the catheter come back up and around. And quite frankly, if it wasn't for this catheter and for stereotaxis, there's no way I was able to get out here with the regular catheter. You can see the sort of the multiple turns you have to do, and that the catheter is not buckling on itself, and I'm not worrying about perforating this person. And one burn out the great cardiac vein AIV area and immediate suppression. So another very good result. Here you can see this was actually a patient who had incessant ventricular arrhythmias as opposed to PVC coming from this epicardial area. It sort of disheartened, and I sort of looked on all areas and didn't have anything, and I'm like, okay, I'm going to have to put this person on a drug. So you sort of go out that area of the IV, and you can see come on ablation here, and then immediate termination, which was very satisfying. Like I mentioned before, these are either wonderfully satisfying cases or incredibly difficult, painful cases to do. But I do believe, and I went from someone who did 0 cases of stereotaxis to doing them for 100% of my ventricular arrhythmia cases, and I've been very happy. And sort of the point being that you can adopt this technology even if you had no experience with it whatsoever during your training. And so, I was able to take the use of robotic navigation and mapping to really have good outcomes. And I agree with Dan, is continuing to publish that that we can do really a good job with these patients and cure them of something that is either life-threatening or causes them significant morbidity and or mortality. So I think that's my last slide. So hopefully, as we open up for questions or anything at all.
Any questions?
I'll make one comment as the questions come in. We talked a little bit about papillary muscle targeting, and with the manual catheter, particularly with that inframedial papillary muscle, you don't know which side of the pap you're going to have to be on typically when you head into the case. And sometimes the right way to approach it with a manual catheter is you want to be on the septal side or the lateral side. For the septal side, going retrograde aortic is the best approach manually, but for the more lateral side of the inframedial pap, you should really go transeptal. With the robotic catheter, it doesn't matter. You go transeptal and you can get all the way around it. Wherever the earliest site is going to be, you'll be able to get to that location if it's approachable at all from the endocardium with the magnetic catheter compared to a manual. And I think that's important. And that doesn't mean that with manual you can't go retrograde aortic and transeptal, but it makes for a long case. It obviously alters the risk for complications during that case. And so that another point of why it's a great modality for these arrhythmias.
Do you go at all retrograding? Do you go at all for retrograding with the stereotaxis?
So you can go retrograde. Generally, depending on what you choose to do in terms of your approach, you usually will need something to get you around the aortic arch, or whether it be a long sheath to sort of get you closer to the cusps. which I have not adopted, to be honest. And my approach to PVCs has been 100% transeptal, and I've had no issues even for cusp PVCs. You actually can sort of double flip the catheter back on itself so that you can deliver lesions, and it's quite easy to do. And I was skeptical, to be honest. I said that I really should do this approach retrograde, but I've had zero issues with being able to do it from a transeptal.
So for the cusp PVCs, what will be your percentage? You go, like even with the retrogradely, you still have to go up, and then
Very uncommon. Actually, so I was surprised at how often I can deliver lesions on the underside of the left or right junction, or normally the left-right junction, and get immediate suppression. And I actually was very skeptical. I thought that no matter what, I was going to have to come on the other side and sort of do that maneuver that I had one recently, but otherwise, pretty much every single case I've been able to get from underneath. And very surprising, to be honest, because what you're really targeting are these muscle sleeves of tissue that sort of extend from the coronary cusp themselves, and had good success. But that was I learned that sort of as I went along from mapping these cases.
So for the
Yeah, and
concept
just if I could add, my approach slightly different, but the same principles. If I think I can get it from the right cusp or the left cusp based on the morphology, and particularly if it's the first ablation someone has, I will go retrograde aortic. If I think I have to go into the LV endo for whatever reason, whether it be triangulating a blade or because there's multiple PVCs, I'll always start transeptal. And if someone is billed as an LVOT, right cusp, left cusp, but they have recurred despite good effort somewhere else, I'll start transeptal on those patients too. But you can go either way. If I'm crossing the valve, I typically want a long sheath. It makes it a lot easier.
what sheath do you use for the transeptal or the retrograde?
For the transeptal? You can use whatever. I use an Agilis, just because. You don't need to use an Agilis. Ben, I don't.
I use an Agilis. No one fights me. Thankfully, at the University of Pennsylvania, they don't fight me how much I use to cost for my cases. That's not necessarily the case for other people. I have found that sometimes the Agilis, you can obviously use it to manipulate a little bit more deflection or less deflection, depending on what part of the left ventricle you're sort of trying to get to. You don't have to. You could use an SL1 or whatever sheath you normally would do for, say, an AFib. But I do. I use an Agilis for all those cases. When I do, and I only have done one case where I've had to do this, sort of go all the way up, you can use a long SL1 that actually allows you to cross into the LV itself, and you can sort of go on the other side of the cusp. But again, I do 100% transeptal for every single one of my cases.
And the retrograde sheath?
If I do go retrograde, well, I would use a long SL1, and it actually allows you to cross. Yes, it allows you to cross all the way, sort of into, depending on how big the arch is, into the actual LV itself.
Will you use an Agilis as well, or?
You can use an Agilis as well. It won't reach to be able to get you all the way into the LV, but it'll get you. You really just have to get over the arch, to be honest.
And like many times, that contact first, the factor they have, it might show you have a very good contact, but it's just with the way how the catheter is bended. So, what do you do for that?
Repeat that one.
Like there is a contact, but sometimes you're not really contacting. It's just like the way, because of the force in the bending, it might give you, you have a very good contact, but you're not. So do you fluoro or what?
Yeah, I try to minimize the amount of fluoroscopy I'm using, but I do like to shoot a little bit of contrast through the tip of the catheter when we're in the coronary cusps and the coronary venous system, because it just gives me a good sense that I do have that good steady contact, and it gives me a proximity to my coronaries. If you're very close to the left main or the RCA, the contrast will go right into it, and again, it allows me to kind of change my direction of the tip of the catheter precisely. So I like to puff a little bit of contrast, but minimize fluoroscopy. And once you get used to the catheter, you know when you're up against something for the most part. If you have a lot of redundant catheter in, that might change, but if you have an appropriate amount of catheter into the chamber of interest and the tip stops moving, you've touched something, and that contact is 5-10 grams worth of contact, and certainly high power is plenty.
And so, yeah, I'll use a combination of fluoroscopy, but actually what I'll normally do is position my ice catheter where I think the PVC is going to be coming from, so that I can see that when I am in contact, you have a combination of things. You have sort of mapping software and some sort of impedance information that can help with that. You have your electrograms, and sort of what would look like a sharp, nice-looking signal. You can step on fluoro for a couple of seconds to see what it looks like, and then use ice. And a combination of all of those things together. And this was another thing I was skeptical about, because I've used contact force since I left fellowship for every single one of my cases in the atrium and ventricle, and sort of felt that it's honestly kind of a crutch for me now for my manual cases, because I know for sure that I'm not going to cause harm, and I know that I'm actually in a level of contact. So that was a struggle for me to not have that information initially, but there are other correlates that you can actually use to be able to determine that you're in good contact in the ventricle, either on the right or the left side.
Sorry, I asked you a question. Thank you very much for the talk. So when you are using your stereotaxis, what you feel on the non-ischemic cardiomyopathy, the septal substrate, posterior lateral, what you feel, you think we have enough, or in that situation still, how do you feel?
Yeah,
because you do a lot of VT.
Correct. Yeah, it's a good question. So what now is sort of a very large percentage of the VT that I end up doing, which is non-ischemic. In regards to reach and being able to get, so we've published at Penn that the majority of this scar is basal perivalvular, sort of right underneath that area. A transeptal approach with this catheter makes it so much easier to reach this area than what I would have to do. And we would struggle. You have these big dilated left ventricles to be able to get underneath. In terms of energy and power delivery, I do think, yes, we talked a little bit about half normal saline and using 50 watts with the catheter for long periods of time. I don't think that use of the system limits you in delivery of energy versus a manual catheter. And the reach and stability that you can get in those areas allows you to deliver very long lesions in an area of what is usually dense and difficult scar to penetrate. And we all know that these cases are tough, and they tend to recur, and they tend to require multiple procedures. But at least to be able to reach that area, I think it's a wonderful tool. And I was, same thing, skeptical to be able to deliver energy that you could, as opposed to, say, the newer generations of an ST or an SDSF catheter that you use for manual. But I've been impressed with the ability to do it if you spend the time, and it's really, that's it. And I think that unfortunately with a lot of these cases, they're complex and they take a long period of time, and we don't spend enough time just honestly burning the scar. And this system allows me to do that without operator fatigue. I can do it for hours and not have to worry about it.
So in the end, you feel with this catheter for this non-ischemic cardiomyopathy VT, you have a probably similar successful rate with your manual, because you are doing more ablation, longer,
exactly
more covered area. So you feel generally
correct. And again, was skeptical at first. I thought that really for these, at first my thought was, well, maybe I'll adopt using robotic navigation stereotaxis for certain cases, but not other ones. And I've changed my tune on that, to be honest. And yeah, I do believe that the amount of time that you can spend doing this without having to, put the patient at risk, put yourself at risk, it has been really a change for me and for our group.
So I think as a community, can we ask the stereotax to do this? Because some people told me they do this using this on the LVAD patient. Some, the company don't encourage. We always begin to see a lot of LVAD patients because that's the trend. Should we, as a company and a group, we need to ask you to test that, because otherwise we never know. We just
Yeah, the LVAD question is a tough one. We have a lot of LVADs at WashU, and we have not used it in the stereotaxis room. We have not done ablation of VT for LVAD patients in the stereotaxis room, and I don't know if there's an official viewpoint on one. The MPLO. Yeah, the jury's still out.
LVAD patient, can we
So I agree with Dan, and we have not done any LVAD. I believe I've heard. I don't know if I'm allowed to say anything while I'm sitting at this podium, but
I think it can be done. I think it can be done probably safely. You know, it's a whole brave new world with the LVAD population, and even with manual ablation, we're still learning, you know, whether it's a good idea or not. I certainly, if I did do a case using this catheter in the LV with an LVAD, I'd be very mindful about the amount of catheter that I allowed to be in. One of the beauties of this catheter is you can throw in redundant amounts of it to create beautiful geometries very quickly. I'd be less inclined to do that in the setting of an LVAD. It can be done. You can control this catheter beautifully in terms of the amount that's in and out and the direction that you're going. In these big dilated LVs, it'll certainly get you everywhere that you want to go. It's just a question of whether there's any issues with the LVAD itself in that particular room, and you know, whether it's better than manual, and we won't know that. When it comes to the septal substrate, I completely agree. Touching that basal septum is very easy with this catheter, and touching the tissue is the first thing you got to do before you can even think about delivering effective ablation. You saw with the data on needle ablation that them just trying to touch and get that needle into the tissue was a challenge with that manual manipulation, so much so that they had to go over to the RV and deliver ablation from the right side. So touching the tissue is the first thing. You're able to use, you know, very safely 45, 50 watts long duration in that area. So, you know, I think it's as effective, if not potentially more effective if contact is better. And then hopefully magnetic VT will give us some insight into whether it's superior or not.
I mentioned this because I do this septal VT ischemic. It's very difficult to penetrate, but I did like, I think Dr. Berhard doing this homogenization. I have a feeling, my gut feeling, homogenization, we do long lesion, we cover everywhere, and that people with so many VT from septal, I get rid of all of them. He's off the minimal amount of anticoagulation. I think what we do, my bias, by doing the homogenization, so sometimes the circuit of the VT surface out close to the endocardium, but we cannot define every part of the circuit. We find the easy part circuit of the potential we target. By homogenize that whole area of scar, you basically increase the chance of reaching all the circuit close to endocardium. You actually overall success. I'm not showing we penetrate very deep, but that's another temporary way to.
And I agree. While it's not the most elegant, you know, compared to the beautiful, you know, Dr. Stevenson pictures of entrainment, it works, and I've had agreed very good success.
Yeah, I see works.
And especially in sick patients who, you know, it's hard to, you know, if you keep them in VT, they're going to decompensate, or, you know, we talked a little bit about the use of Pello, or we use ECMO a lot, obviously, at Penn, but allows you to do this in sinus rhythm and have good success and non-inducibility.
I see the fellow from Brigham, a very smart guy. He go to there in train, do that to stop it 3 beat, 4 beat, and a few days later they come back. They do very limited ablation sometimes, but they try to homogenize. Not get me wrong, they also homogenize. But I feel similar case. I do. It seems like ugly because you ablated all the area.
Yeah.
The technician was sitting there and said, "What are you doing? Are you doing VT ablation or you ablated the ventricle?" But at the end of the day,
It's what happens.
our result is better. Yeah. I tried either way. Homogenization is better. I hard to deliver this to me, but without limited mapping and standard circuit at this point, I think homogenization is still at the end of the day.
I remember I was a fellow, and it was a Friday about 7 p.m. We sort of spent a lot of time mapping. We found a beautiful non-propagated stimulate. We burned, one burn, terminated, great. I'm like, and then I go to the attending. I'm like, oh, this is great. We're done. He goes, are you kidding? He goes, Ben, we're going to be here for hours, strap in, and hours later, burning. I was like, huh, that was interesting. And so it was sort of a teaching moment for myself, and I agree completely. And I think the field is sort of moving that way as well.
All right. Thank you, Dr. Cooper. Thank you, Dr. D'Souza.